Hello everyone, I'm Dr. Angela Mattke and you're watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. I'm a pediatrician at the Mayo Clinic Children's Center in Rochester, Minnesota. Twice per month I host a show about pediatric health topics where we take and answer your questions live. Today we're talking about the management of daytime bladder leaks in children. This is a concern that can lead to major distress for both families and children. However, there are safe and effective treatments that we will be discussing today. We have two experts from Mayo Clinic Children's Center joining us for this discussion. The first is Erin Kieley, who is a pediatric physical therapist with special expertise in the management of bowel and bladder dysfunction in children. Our second guest is Dr. Candace Granberg, a pediatric urologist and assistant professor of urology at Mayo Clinic. It's going to be a great discussion today, so please send in your questions now under the Facebook Live video feed, and we'll try our best to review them during the live video broadcast today. So Erin and Dr. Granberg, thank you so much for joining us here today.
Thanks for having us.
Thank you. Hopefully this will really help a lot of families and know more about information and possible treatments that are out there for kids that are struggling with leaks during the daytime.
Yep.
And maybe in a different show we can talk about bedwetting a little bit more. But if people do have questions on that, please feel free to send them in. But our main focus today is going to be on daytime leaks and daytime incontinence. Yep. Right. So Erin, tell us a little bit about this. So you work as a physical therapist in the Mayo Clinic Children's Center. How does physical therapy relate to accidents in children?
Well, I have the honor of working as part of the pediatric urology team in providing physical therapy and rehab of the pelvic floor muscles, and I work with kids with dysfunctional voiding issues, kids that have problems holding their urine or stool, kids who have leaks, kids that have had recurrent urinary tract infections, all sorts of different issues that are referred to me because our patients typically will see Dr. Granberg or Dr. Gargoyle first as a part of our pediatric care team.
Okay. So people sometimes don't think about muscles being involved in bowel and bladder dysfunction and how leaks occur. Tell us, did you need to get special training in this area to be able to help children with these concerns?
I have chosen to get specialized training. It's not required, but it is strongly recommended because working with kids is very different than working with the adult population that do have incontinence issues. Kids a lot of times they just require a different approach, and my approach is I don't do anything internal with the children because most of the time, by the time kids come to see me, they've had lots of invasive tests and uncomfortable tests, and you can just see the stress kind of leave them as I tell them, nope, we're not going to be doing anything that hurts. But it is, the training is important. There's an important distinction there, and it's a different approach when you're working with kids and families.
Absolutely. Dr. Granberg, how about we talk a little bit just to set the foundation for understanding this? When do kids typically become continent or potty trained is the other term that we sometimes use? Tell us a little about that.
So I think the most important message we try to tell families when they come in either prior to toilet training age or the children that are coming to see us that are having trouble is children really dictate when they're ready. And so the American Academy of Pediatrics also supports the readiness factor of a child, and there should never be a cutoff that says your child should be potty trained by this age before they can advance to the next preschool classroom or other areas. So I think the thing that we have to remember is it's a developmental milestone.
Absolutely.
And not every kid walks at the same time, not every kid talks at the same time, and you'd never think to hold a child back from moving forward in their activities because of a developmental milestone. And so the child will actually tell you when they're ready. And so we don't ever want to force a child into being potty trained. Boot camps, potty train your child in one day for the factor of getting out of diapers or pull-ups. And when the child's able to verbalize, I'd like to go potty, they're ready. And then you do then try to set a schedule for them, because what we don't want is a child that learns to hold for too long, or a child that's being told you need to go every 30 minutes because we want you to be dry. And so we want socially acceptable periods of time for them to be dry. And so we try to tell them as soon as they're interested, try to put them on the potty about every 2 hours. And then they'll start to get it, they'll start to sense things, and they'll be ready. Urine continence usually comes first, bowel usually follows, nighttime is the latest. So that's why, as you said in the beginning, bedwetting could be a whole other topic, because we really need to hammer down daytime first before we can address the bedtime.
Absolutely. And nighttime bedwetting, is that also going to be a developmental milestone that's really dependent on the child and where they're at?
It sure is.
Okay.
And it's certainly delayed past the age of daytime toilet training,
Okay.
sometimes by years. And it just takes longer.
Okay, sounds good. Well, let's talk a little bit more about, so if a parent had a child who was having leaks, sometimes they worry that maybe there could be something else going on, maybe something physical, or maybe something more mental or psychological. What would you tell a parent with where to start with their concerns?
So we would like them to be evaluated by their primary care provider, whether it's a pediatrician or a family medicine provider, to just at least look them over from head to toe and make sure their anatomy is okay. You know, sometimes it's a skin issue, or there really is something going on that has never been diagnosed before, and we want to make sure that we've checked all of our boxes to say anatomically the child is normal. We've tried some conservative measures, and then if it seems like things are not lining up, then sending them a referral to pediatric urology, where we'll assess them, and then we can decide if they need Erin services as well.
Okay. Are there any testing that you would do as part of this evaluation to figure out if there is something underlying that's contributing to the leaks?
You know, infections are pretty common, even especially without fevers. And so sometimes we'll start with something as basic as a urine test to make sure that they're, you know, not having an infection or blood in their urine or protein or sugar in their urine to cause irritating symptoms to the bladder that lead to accidents. And a simple pee in a cup test is great. Sometimes we'll do tests to make sure they're emptying their bladder okay. And again, these are all non-invasive, just like Erin said. Children are different, so there's no catheters or anything involved. So we'll sometimes do an ultrasound, and we'll sometimes do a flow test where they pee into a special potty. It measures how much pee comes out, how fast their pee comes out, and then we do a quick ultrasound to see how much they're leaving behind. And those things really can rule out a whole lot of very scary bad things to say, nope, this is just developmental, but we can help you get there.
Okay. Are there other things like constipation that can contribute to leaking during the daytime, or not being able to achieve that continence going forward?
I think we'd all agree constipation is probably the number one reason kids have daytime bladder leaks.
Okay.
And it's a misconception that if your child is pooping every day that they may still be constipated, that they may not be constipated. And so, you know, Erin will talk a little bit about that, I think, as well, but the, you know, having poop sitting in there, it certainly pushes on the bladder, can cause bladder spasms, and there's nothing we can do medication wise, surgery wise, to fix that until you get the poop under control.
Okay, so if you're a parent and your child's pooping every day, how do you know that they're constipated? What kind of signs would you look for? Do you want to take that one, Erin?
Well, definitely. You want to look for signs. A big sign is, and a common misconception is that if you see skid marks or stool streaking in your child's underwear, that most parents, and myself included, think, oh, well, it's just due to poor wiping. Actually, that's typically a very, very big red flag for constipation. Other red flags include, your child having to strain or have painful bowel movements, taking a long time to have a bowel movement. If your child's in the bathroom over 15 minutes trying to have a bowel movement, chances are they're pushing and they're having a hard time evacuating stool. Another sign will be complaints of abdominal pain.
Okay.
Tummy aches, that kind of thing, and that's something that's definitely important to talk with the primary care provider about. Also urinary urgency, constipation is, kind of one of the biggest contributing factors to that. Another thing is what we call the holy cow poops. Where your child has a bowel movement that either clogs the toilet, or you look at it and you say, holy cow, how did that come out of you?
Exactly.
So, those are kind of the red flags. And it, like Dr. Granberg said, it plays a huge role in urinary issues, bedwetting, even, daytime leaks, that kind of thing.
Okay. Do we have, is there like certain types of stools that they should look like for parents? Is there a guide that we can talk about to say, like, this is what a normal stool looks like, this is what it doesn't?
Yes, I think we've got a graphic as well. So this is a handy chart that is available also on the bedwettingandaccidents.com website. But it's important to have your child and you also to be looking at your child's bowel movements every day. The goal is to have the top 3 types of bowel movements up there. The smooth, mushy snakes, we want them formed but soft serve ice cream. When you see stools that either look like rabbit pellets or bumpy sausages, that's indicative of constipation. And so this is a really handy chart. but it also, gives parents an idea of what to look for. I think that's really helpful. I didn't know that before coming into
Right.
this
I feel like
specialty.
that's something I've learned more and more as we go through, and I work with you guys and referring patients that are struggling with these things. So thank you for helping educate me about those things. Yeah.
On the inside, I think what we need to remember is the bladder and the bowel sit back to back. And if a stool's sitting there long enough to make those rabbit turds or thick bumpy sausages, it's sitting there long enough and it's constantly contracting. It'll push on the bladder and you'll have a leak. And it'll push on the bladder daytime or nighttime. And the urgency that Erin was referring to is the gotta go right now, you're not going to make it in time. And that's almost always secondary to poop pushing on the bladder from the backside. And again, there's no amount of medication or anything you can do to fix that until the poop is evacuated.
You mentioned leaks and that gotta go urgency. We have a great audience question about this before we kind of get to what treatments would be helpful. So this is a little girl who does have chronic constipation. She can't control her bowel movements at night. What treatments would be helpful? And then we also have another question about a little girl who laughs and leaks urine when she giggles or laughs or sneezes. So let's have you kind of try and address those questions.
I think we'll talk about the giggling one first because that one's a quicker one.
Yeah.
So giggle incontinence itself is actually a real diagnosis. It's enuresis rhizoria or giggle incontinence, and it really is the only symptom. So they don't have incontinence any other time, and there's really no associated urgency. They don't sense that it's coming. They're not going frequently during the daytime. The only time it happens is this huge response in the body that they just let go of their urine when they laugh. And so the neurology or the basis behind it is not really well understood. But at one point there were some studies done on medications to see if we could fix this with a medication, and the medication was Ritalin. And so it's controversial because you need to have a prescription for it. It needs to be filled every month. You need to see a provider to get the prescription. But a lot of these kids that get placed on that medication for pure giggle incontinence are dry. And it may be something they grow out of. It may be something that, in fact, if you ask all of the family members in the family, yes, this aunt, this grandma, they all have giggle incontinence. So it's probably inherited, and it might be something that they could potentially suffer with for life if they don't get help early. So one option is medication, which would be the Ritalin therapy. And another is biofeedback, just like Erin provides. And so at some point, during their development, they can learn ways to sense and control things. And so we offer non-medication options, biofeedback therapy, or medication.
Okay, let's talk a little bit more about how you have treatments available in physical therapy that can help with incontinence during the daytime.
Yep. One of the biggest tools that I use in this clinic and with kids is biofeedback, which has been around a long time in the rehabilitation world. Basically what biofeedback is, and I've got a couple of things here to show, and this is just a little, model of the pelvis. This is looking from the top down. The pelvic floor muscles inside the pelvis, they basically act as a sling or a hammock to hold up, to support all of the organs. I tell the kids it's the guts, intestines, organs, pee and your poop, everything. So they're kind of important muscles. When we look at the bottom, anatomy the other way, we can see here that all of the red are the pelvic floor muscles. The pelvic floor muscles surround both the anus and, the vagina and the base of the penis and that kind of thing. What biofeedback is and how it helps kids with incontinence issues is when kids that have leaks, whether daytime or nighttime, a lot of times these muscles are squeezing when they're not supposed to, or they're not relaxing when they're supposed to, when they're trying to void. And so we use in this clinic, but what I use are these little sensors that get placed just right around the perineum here, okay? And the kids can look at, and these sensors pick up how strongly the muscles are contracting or how much they're relaxing. And the kids get that immediate feedback on the computer. Right. So they can make different colored mountains and valleys. And when they make the mountains on the screen, it means the muscles are squeezing. Right. When they make the valleys, that means the muscles are relaxing. Right. But having that external feedback is really, really important. Because most kids that have issues with continence and are incontinent, they have no idea what those pelvic floor muscles are doing, and they've never, and so it's a whole new learning curve, but it's extremely helpful, especially with kids that have a history of withholding, and going long times, between urinating or having bowel movements. There's a lot of retraining that needs to happen there.
They've lost that sensory feedback to their brain, and you have to kind of retrain that.
Yep.
and redevelop
Yep.
it.
And
Okay.
the muscles just get so used to squeezing and holding that the muscle systems forget how to even relax when they're trying to void.
Great.
And I think this goes back to your comment, the question that came up about the child with the chronic constipation. These kids are super holders. I mean, they say, I can hold my pee all day long. I don't pee at school all day. At one point in time, they probably had a really painful bowel movement, and they think to themselves as a toddler, I'm never going to poop again. And they get that pelvic floor so strong that they don't know how to relax their urethral sphincter to let out all their urine and their anal sphincter to let out all their poop, and they'll either have poop leaks or they'll have pee leaks, and it's just a vicious circle then. And so the difference, I think, in what Erin does compared to grown-ups that go to a physical therapist for biofeedback therapy is we really need to teach these kids how to relax those muscles versus Kegel exercises where people are trying to get stronger.
Right.
These kids are
The
super
opposite.
strong.
Yeah.
Yes, we need to teach them how to relax, but a lot of sensory integration of how to understand your body's response. A lot of parents question, I don't think they feel that they can go. I don't think they can feel when they're full. And, how are we supposed to teach them that? And that's where we just need to put them back on a schedule. And no, you might not feel like you have to pee, but it's time to take a potty break, and using the verbiage with the parents to make it not something that you're forcing them to do, making them a part of the process. We have watches that we let them get that vibrate so that they feel like they're in control, and they may not feel like they have to go, and that's okay. That doesn't mean that they're abnormal.
Okay. How often do you encourage families to teach their kids to take potty breaks?
In a typical day, most kids should be going about every 2 hours during the daytime, and that sounds like too much for a lot of parents, but what I tell kids is you should go first thing when you wake up in the morning, even if you had a wet night, once in the morning at school, lunchtime, afternoon, supper time, and bedtime. That's a really good basic schedule because kids are sleeping for a good time at night.
Right.
And if you're drinking more, you're going to have to pee more. Just like if any of us drank a coffee or something, we'd have to pee extra. So that's the baseline amount most kids should be peeing. And then their next question is, how long do they have to do this? And I say, realistically, for life, we all should be peeing every couple hours.
Right.
They chuckle and say, I don't pee that often. And I say, well, we should. And then we're setting good examples for our kids. Family bathroom breaks, especially before car trips and things to make it a good habit for everybody.
Fantastic. With the biofeedback, Erin, is this a process that they would continue to do at home, or is it something they do just usually during appointments with you?
Well, my job is to teach the child and the parents how to do this at home because they need daily training. And so the parents are very much a part of the home exercise program. And I have the parents right up there with me and teaching positioning. And, that's really the biggest piece and the biggest role that parents play in the whole process is really helping their kids with these exercises, whether it's holding a mirror so that they can see their bottom muscles. I teach the parents what it looks like, what their the child's pelvic floor should look like, what a squeeze looks like, what a relax looks like, what a Valsalva looks like when the child is bearing down, which we don't want. So they play an integral role. The children are responsible, and typically I start seeing kids around age 6 and up.
Okay.
But typically that's at an age where I expect the kids to be able, I want you taking sips of water, regularly. I want a water bottle with you all the time. I expect you when your watch does go off and vibrates, go sit on the toilet, whether you feel like you have to go or not. And so, even though it's not the child's fault that they're having these leaks, I do expect them to take some responsibility for their bodies and try to relieve the parents of that duty of, time to go. Oh, yep, got to go sit on the toilet. Because when kids get to take ownership of their bodies and what's happening to them, they tend to be invested in it more.
Is there any specific kind of language that you use with the kids to really get them to take that ownership and to encourage them in some type of positive sort of behavioral program?
Absolutely.
Okay.
Absolutely. So I make it very clear to the kids, the child and I, we are a team.
Okay.
I really try to have I tell the parents that they're typically the cheerleaders on the sidelines, and the kids really like that, and the parents like that too, because, oftentimes there's been a lot of headbutting and conflict. And I tell the kids, if you get mad or frustrated with this, you can get mad at me. I'm okay with taking that on. But I very much use I tell the kids, I'm your bladder coach. And you are accountable to me. Mom and dad are the cheerleaders. But I also really encourage the kids and make it very clear, we are all here to help you get dry. That is the goal. But only one person can really take responsibility for your body, and that's you.
Okay.
Yeah.
How do you teach the child to empty and kind of fill their bladder and learn to sense that at regular intervals?
Well, the timed voids are a huge part of that. Part of the child's homework for every one of my patients is that they drink a lot of water. And I make the analogy of, I usually try to use sports as an analogy because, athletes train and they practice to teach their muscles how to speak, or their brain to speak to their muscles and joints and how to move. The bladder is a muscle. So I use that analogy. We have to train the bladder how to behave. And so drinking lots of water is part of the filling. And then, sitting at regular intervals every 2 hours is part of the emptying. So we're training the muscles how to behave. The other piece is I do work with families and, mainly kids, with to work on sensory training and teaching the children what a normal urge would feel like. So that's another component of the program that that I incorporate.
Okay. How long does the program usually last, or is it very variable depending on the child?
Typically, it's I typically see kids for 4 to 6 months on every 2 to 4 week basis. I give them their homework. I have homework charts and sheets that they stay accountable with. But it's typically the first 2 visits are about an hour and 15 minutes long. And then after that, we hit the ground running at about 45-minute long appointments and progressing the home program as we're able, working with our team to manage the constipation. That's one of the great pieces of our team is that I can walk down the hall and say, hey, Dr. Granberg, I'm wondering if we should consider trying medication for this kid, or we're having these issues, what other testing. So there's really a lot of great communication that takes place. But back to your question in terms of what we're trying to achieve, it's really a comprehensive approach and a team approach.
Okay. Is there important messages or language that you use when discussing this with patients and families regarding these leaks?
Absolutely.
Okay.
Absolutely. Yeah. So a lot of times kids and families come to see us and they're very frustrated. The kids, a lot of times have blame and shame. Because they're embarrassed, and this is an embarrassing topic, and this isn't something you bring up at the soccer game even as parents. So I try to tell the families, please take the word accidents out of your vocabulary, because the word accident implies blame and shame. It's not intentional. I've used it with my kids, but it just feels icky when you ask a kid, how does it feel when you hear the word accident? And they just, doesn't mean anything good has happened. So I explain to the parents and to the kids, blame the appropriate organs that are causing the problems. It's not you, Johnny. It is your bladder. So I have my little stuffed bladder that I point out, and I tell blame the bladder. This is the organ causing the problem, not you. I have a little. This is my stuffed colon. They do make stuffed colons. Who knew?
Is it filled with real poop?
I hope not.
Smells okay.
I do have a keychain that looks just like this too. But blame the colon for you. If you're having poop leaks or constipation, get mad at this colon. And it's important to separate who the child is from what these organs are doing in their bodies, because it so affects their self-esteem and who they are as little people. And we just want to take any blame away from that. So I refer to them as leaks, poop leaks, pee leaks. And, when parents, when I have them check in and ask, I say, you want to ask, okay, Susie, did your bladder leak today at all? It sounds very different than, did you have an accident? Right.
Exactly. Right. I really like that language, and hopefully I can take and incorporate it into my practice as well. You mentioned medication. So, Dr. Granberg, is there a role for medications in the treatment of incontinence, especially during the daytime?
There is. So there's some kids whose bladders are just overactive, and so you hear overactive bladder in the adult population, and there's certainly a whole host of medications for grown-ups, but it comes in liquid form for kids as well. Very few kids will need that medication, but some do. The biggest concern is, what is this medication going to do to my child? The goal for us is that it stops the bladder from squeezing when it shouldn't. And so it calms the bladder down so you can hold more pee comfortably, but still be able to squeeze and empty when you need to. The biggest side effect of that medication is constipation. So if we don't get their poop in order first, they cannot be on that medication. So once we do their clean out and they're on maintenance therapy for their poops, then we see, are you still having that gotta go right now feeling? Are they still having daily leaks? Have they, gone through biofeedback or not? Sometimes we use it in conjunction with biofeedback. And we start at a low dose and we can always give more. But we obviously don't want to put kids on medication if we don't need to. So our goal mantra is rehabilitate, don't medicate. And so if we can do things without medication, we try our best.
Absolutely. Parents and kids have been dealing with this for so long. There's probably just this urgency to try and get it fixed and to get it done with really quick. But this is really a long process. It takes a while, it seems like, to retrain the bladder and to retrain the bowel and get the constipation under control.
For sure.
Is that a big part of your message?
We do.
Yeah.
We say this didn't happen overnight and it will not get
Yeah.
fixed overnight. So starting a medication would not fix this. Again, it's really kind of a muscle problem. And if you've learned to hold, to learn how to relax over time takes a long time. And the multiple visits, the exercises at home, practicing just like you're on a sports team, it's going to take some time. And I think, as she said, it's going to take a lot of players. So school is a big part of this.
Yeah.
I know that, we talked more about bathroom policies at schools and how frustrating it is for some of these kids who got to go all the time, but yet they're being told you get one bathroom pass per day, per week, per quarter. I've heard a whole host of different reasons, why a child shouldn't use the bathroom. And of course, they don't want the policy being abused and everybody's getting up to use the bathroom. But who's to tell your bladder 10 o'clock is when you're going to need to pee today? And so we really try to...
Bladder doesn't get that message sometimes.
Yeah. So yes, there are breaks in school day when we try to encourage kids to build their bathroom breaks around those times. But we certainly have sent messages home with parents to take to the school that says, please allow so-and-so to use the bathroom every 2 hours and as needed due to medical necessity. Because it's true, they need to do this.
Absolutely. I've done many letters over the years for parents. So I would encourage families out there really to not be worried about asking us for that. We're happy to do anything we can to advocate and to help with this process. So as we kind of wrap it up here, let's summarize for families, how would they go about getting their child help?
So step number one would be talk to your pediatrician or your family medicine doctor to say, my child's having trouble, what can we do? That provider will probably do the basics of how often are you peeing and pooping. They might do some basic testing and then send them on to pediatric urology if they feel that they need to escalate their care. And then we triage them to say, here's what you're going to do. Number one, poop. Got to get the poop out of the way. Clean out, maintenance therapy, pee on a schedule. And then some kids that we triage will need biofeedback therapy, so we send them to Erin. Or if they're not from around here, we can find a provider closer to home who offers similar services for pelvic floor therapy for children. And we keep close tabs on them. We don't say, we'll never see you again. We want follow-up. We want feedback to say, where are they at? So we send them home with voiding diaries and poop diaries to track their progress so that we can intervene. We don't want them going home thinking you're just going to grow out of this. This is the way they're going to be until they become dry.
And sometimes you include pediatric gastroenterology in this
Absolutely.
as well? Okay.
Yes, our PEDS GI team is fantastic, and we can certainly tell that there's some kids who, for one reason or another, need their services as well, and a workup to make sure that there's not something underlying that's causing the poop situation to be so severe that it's affecting the bladder, where we're here to help them.
Absolutely. Well, what resources would you recommend to families out there that they can look to and use at home if they don't have resources near them?
There are a lot of great resources. The resources that we utilize most of the time, there's a great website. It's www.bedwettingandaccidents.com. That site is run by a pediatric urologist, just like Dr. Granberg, and named Dr. Hodges. And it's a wonderful resource for parents. The blog section is fantastic. There's lots of great information to help parents and kids not feel so alone in this. So, the website is a great place to start. The International Children's Continence Society has a lot of helpful information on there. So I believe that website is iccs.org. And then there's also another book called It's No Accident by Dr. Hodges, and that really goes through kind of the physiology and understanding, urinary tract infections and, constipation and daytime leaks and all of those things. So we have a lot of our parents and families that go through this program read those books. And then there's a kid's version of the book called Bedwetting and Accidents Aren't Your Fault. And it's a great book, a lot of really beautiful illustrations, and that book, and it's available on Amazon. All of these are available on Amazon. But those are some fantastic resources for parents and kids to get started on.
Thank you. Thank you so much, both of you, for joining us today.
Thanks for having us.
We'll have to talk more about bedwetting and at night
For sure.
in a different episode. So. And thank you, everyone who joined us today. Thank you for all the wonderful questions. If we didn't have time to get to them during our broadcast, we'll try to connect with you offline. Join us for the next Ask the Mayo Mom on July 12th. It'll be at 11 a.m. Central Standard Time. Our experts will be Dr. Kofer and Dr. Mardini, who are both experts in the treatment of cleft lip and palate. So please join us that time for the discussion. Thank you, everyone. Have a wonderful day.